Hey guys, welcome back to my channel. So today we are going to discuss about a very important topic, that is chronic obstructive pulmonary disease. We all know a lot about it, but there's a phase, there's some steps we need to follow while diagnosing COPD and while treating COPD. Fine. Now we'll see a very basic things, and we will see the updated things that has been added in 2022 to the guidelines of COPD. So first of all, definition that will remain unchanged. COPD is common, preventable and treatable disease that is characterized by a persistent respiratory symptoms and airflow limitation that is due to airway or alveolar abnormalities, usually caused by a significant exposure to a noxious particles or gases. Chronic airflow limitation that characterized COPD is characterized by a small airway disease. We have to remember that COPD is a small airway disease and it also involves parenchyma. So there's also a parenchymal destruction. Coming to the pathogenesis, it can be due to the genetics, alpha-1 antitrypsin deficiency, or it can be due to some host factors, that is smoking, indoor air pollution, long-term smoking practices, infections. So if there is a genetic susceptibility, that will what it will cause, it will not allow the lung to mature enough. And if it is due to some free factors, so that can lead to the production of free radicals and inactivation of anti-protease or overproduction of protease. So that will lead to lung inflammation due to oxidative stress, release of cytokines and protease function. Now it is going to affect at two places. One is at the bronchial tree and other is at the lung parenchyma. When it is working at a bronchial tree, what it is going to cause? It is going to cause infection over there, inflammation over there, release of neutrophils, leading to fibrosis and narrowing of the airway. One. Second, there will be mucus plugs. These mucus plugs will go inside the alveolar parenchyma, leading to the nidus for the infection. And third, there can be a death of a airway epithelium. All these factors are going to cause a chronic bronchitis state. Second, when there is a proteolytic destruction of the emphysema of the lung parenchyma, leading to emphysema walla picture, that is decreased airway elasticity, leading to the trapping of air inside the alveoli, decreased structural supports causing airway narrowing and collapse, and a permanent enlargement of alveoli, leading to hyperinflated lungs and bullae. Now, chronic bronchitis and emphysema together they form chronic obstructive pulmonary disease. What are the clinical features? Again, we will go with the same flow. There is a damage to the lung uh, tissue that causes the decreased elastic recoil, causing when you expire, now the lung parenchyma has weakened, so the expiration will take longer. So there will be prolonged expirations. Now, lungs will never fully empty. There will be some amount of airway trapping. So this airway trapping will keep the chest inflated all the time, leading to a barrel chest. And second, there will be a rapid shallow breathing. Now, in the later stages, what will happen? Your diaphragm will flatten down. Now, when the diaphragm will flatten down, when you'll try to inspire, what will happen? The lower ribs, they will pull inwards, leading to Hoover's sign. Usually, at inspiration, our chest should expand, but in Hoover's sign, what happened? The lower ribs move inwards, leading to a Hoover's sign. All this is taking a lot of efforts of yours, leading to dyspnea. Second, during expiration, there is a positive pleural pressure which squeezes the airways, leading to shortness of breath and narrowing of the airways, leading to expiratory wheeze. Third, now there is a reduction of ventilation of the alveoli, leading to reduced oxygenation of blood, reduced perfusion of the tissue, leading to fatigue, reduced exercise tolerance. Now, because of increased mucus production, all the mucus will keep on collecting over there and there will be a chronic cough with sputum. Now, at the end stage, there are four things that you need to remember. A patient will try to expire more than the inspiration, so more of the air has to be expired out. So there will be a pursed lip breathing. Second, there's a lot of efforts of the all the muscles which are taking place, leading to fatigue, muscle weakening, and also wasting. Now, The patient tries to breathe with the accessory muscle, with the pectoralis muscle, leading to a tripod position, and second with neck muscles, sternocleidomastoid, with all the muscles ala nasal, leading to use of accessory muscles. What are the complications that can occur with COPD? So first, because of a lot of inflammation, a lot of goblet cell proliferation, release of cytokines, mucus, there occurs trapped mucus, trapped air, causing acute exacerbation of COPD and pneumonia. Second, because of a lot of efforts and a lot of energy, and patient goes into a catabolic state, leading to macro and micronutrient deficiency, leading to wasting of muscles, protein, energy, malnutrition. Third, now this airway obstruction reduces the inhaled air in the alveoli. Now this inhaled air will cause reduced oxygenation. So to fulfill the oxygenation, there will be activation of erythropoietin, which will cause increase in hemoglobin and secondary polycythemia. Then, because now there has occurred hypoxia, this hypoxia will cause pulmonary vasoconstriction, which will cause a lot of pressure on the right ventricle. So, right ventricle will hypertrophy, causing pulmonary hypertension, and in the later stages, they will cause cause pulmonary. Now, because the patient thinks he is not in a good state, he is always having difficulty in breathing, he cannot walk, he cannot do his household rituals, he cannot do his financial work, that causes depression to the patient. Now, these alveoli, the emphysematous bullae, they might rupture, causing to the risk of pneumothorax. So now these are the new guidelines, and most of things we know, but some things have changed. So let's see to that. Now, symptoms: shortness of breath in the later stages, chronic cough with sputum. What are the factors? Tobacco, indoor air pollution, occupation. How you will diagnose it? The spirometry is very important to diagnose it. Now, this is a graph which shows the FEV1. So, FEV1 upon FVC curve, it should be less than 0.7 to diagnose your COPD. Now, these are the investigations you need to know for the airflow obstruction and for the lung capacity. Now, on ABG, you will see a PaO2 of less than 70 and PaCO2 of more than 45. That shows that a lot of CO2 remains inside the alveoli, and that is good. You need that alveoli inside it. So, CO2 retention is good. So, we need not give a lot of oxygen to such patients. There will be high alveolar to arterial oxygen gradient. Okay, then due to inspiration, there is a positive pleural pressure which causes a longer expiration time. So FEV1 upon FVC will be less than 0.7. When you have taken a chest X-ray PA view, you will see more than 10 ribs, and you will see a flat diaphragm. There will be a lot of air occupied inside it, with which give a high total lung capacity and high vital capacity. Then air does not block the beam of light, so you will see a lot of blackening on the lungs, and on the lateral X-ray you will see a retrosternal airspace. Then lung parenchyma, what you will see that there cannot be a lot of gas exchange due to reduced surface, or your DLCO, diffusion capacity, will be reduced. Now, you should know the small airway disease assessment. This includes spirometry, widely used. It includes FEV1, FVC, FEV3, FVC, FEV upon SVC, then body plethysmography, multiple breath nitrogen washout, impulse oscillometer, HRCT, which is easy, non-invasive, which tell you about the thickening of the airway, airway trapping, then regional ventilation defects, and non-ventilated lung volume, and also fractional excretion of nitrogen oxide. Now, SAD, don't be sad from SAD. SAD tells a lot of things about COPD. SAD starts early in the course of COPD and contribute to the rapid decline in FEV1. It has integrated many grades of COPD, and there's a new grade over here, that is inspiratory and expiratory reactance, which is measured by 5XZ delta XS. If it is more than 2.80, it is pathognomic of COPD. Now, how you will diagnose, how you will come to the diagnosis: if your dyspnea is progressive, it worsens in the evening, and it worsens on exercise, and it is persistent over a longer period of time. You have a chronic cough that is associated with sputum. There's a lot of recurrent wheeze. Sputum, we have already told. Recurrent lower respiratory tract infection. There's a risk factor, there's a genetic factor, family history, host factors, Then occupational disease, indoor air pollution. This contributes to a lot of diagnosis of COPD. Now, while performing spirometry, now this becomes very important that first of all you have to give a patient a short-acting bronchodilator and a short-acting anticholinergics, 500 microgram of short SABA and 160 microgram of short-acting anticholinergics. And after 10 to 15 minutes of SABA and 30 to 45 minutes of short-acting anticholinergic, you have to go for a spirometry. So it's a post bronchodilator spirometry in which FEV1 upon FVC का अगर ratio is less than 0.7, that makes a diagnosis of COPD. Next, you can read. See, this is a normal lungs in which the FEV1 upon FVC ka ratio is 0.8. But now in this graph, you have a FEV1 upon FVC ratio 0.56, which is suggestive of COPD. Mild, now you have to see the FEV1 predicted. FEV1 predicted more than 80% mild, FEV1 predicted between 50 to 80% moderate, between 30 to 50% severe, and less than 30% is very severe. Now you have a CAT assessment chart in which you ask the patient, do you cough all the time? Do you have breathlessness all the time? Do you feel a lot of phlegm mucus in your chest? Do you feel tightness in your chest? Do you have difficulty in walking uphill or one flight of stairs? Are you able to perform only limited activities at home? Uh, don't you feel very confident like you will be always breathless? Are you able to sleep at night, or your sleeps are very irregular and very unpleasant? And do you have energy all the time, or you are low at energy? And then you calculate the score. That's a CAT score. Now, these are the DDs of COPD. In COPD, it will occur midlife, around 40 years of age, with slowly progressive, with a history of tobacco smoking or a family history suggestive of COPD. Then in asthma, this will occur early in the age. There will be history of atopy, eczema, family history will be there. It will worsen at night or early morning. Then obesity will coexist along with asthma. Congestive heart failure, your chest x-ray will show a bit of cardiomegaly and bad wing appearance, pulmonary edema. Your spirometry will show a restrictive pattern rather than an obstructive pattern. In bronchiectasis, you will have large volume of purulent sputum, and on HRCT, you will have a bronchodilation and bronchial wall thickenings. Tuberculosis, it will be associated with moderate grade fever, evening rise fever. Your sputum will be positive. Your chest X-ray will show heterogeneous opacities. Then they'll have a history of contact with someone in the family or in the neighborhood. Bronchiolitis obliterans, a younger age group, non-smoker, history of rheumatoid arthritis or acute febrile illness. CT will show hypodense areas. Diffuse pan-bronchiolitis, it will be a male non-smoker, predominantly Asian descent, almost have a chronic sinusitis, and HRCT will show nodular opacity. Role of spirometry is not just in the diagnosis, it is also in the prognosis and also in change of the treatment, or you need a alternative treatment, or you have to go for interventional strategies in the treatment of COPD. Now, vaccines are very important. If your patient is less than 65 years, is FEV1 is less than 40% and associated comorbidities, you give a pneumococcal polysaccharide vaccine. If the patient's age is more than 65 years and reduced chances of community acquired pneumonia, you give pneumococcal conjugate vaccine. And against a whooping cough, you give a pertussis vaccine. Now, these are the drugs which are used in the maintenance of acute COPD. So you have a short-acting beta agonist, short-acting anti. So you have a beta agonist and you have an anticholinergic. Inside the beta agonist, we have a short-acting beta agonist and a long-acting beta agonist. Short-acting beta agonists are phenterol, levoepitrol, salbutamol, terbutaline. Long-acting are formoterol, indacaterol, oldacaterol, salmeterol. Then in anticholinergics, short acting we have ipratropium and oxytropium. In long acting we have aclinidium, glycopyrrolate, tiotropium, omeclidinium. It's a new one. Okay, and you have a levofenicin. Now, these days you are more into combinations of SABA with SAMA, with SABA, SAMA, along with inhaled corticosteroids, or LABA, LAMA, along with inhaled corticosteroids. Okay, so you have this. Methyl is not in much use, but these are aminophylline and theophylline still used at government hospitals and small hospitals. Then you have a combination. We have already told formoterol with budesonide, formoterol with mometasone with beclomethasone, triple combination, LABA, LAMA, inhaled corticosteroids. You have a phosphodiesterase 4 inhibitor, roflumilast. We have a mucolytics again. They reduces the acute exacerbations again. Adenosine, carbocysteine, and acetylcysteine, which is mostly used. Now, anti-inflammatory therapy, it has shown that anti-inflammatory therapies, they reduces the risk of moderate and severe COPD, and oral glucocorticoids are of not much use and which should not be used. PDE5 inhibitors have shown to reduce the exacerbations. Antibiotics, long-term use of azithromycin and erythromycin are very good to reduce exacerbation over 1 year. Mucoregulators and antioxidants like N-acetylcysteine helps to reduce the risk of exacerbations. And then we have other anti-inflammatories such as leukotriene modifiers, but it has shown that they have not been yet tested adequately in the patient of COPDs, and statins are again not much of the use. You should also counsel the patient for brief smoking cessation, which is very effective, and every tobacco user should be offered such advice at every contact. Second, you should tell a tobacco user, dependent user to go for a varenicline, bupropion, nicotine gum, nicotine inhalers, nicotine sprays, nicotine patches. Now, in the acute care, a patient coming to you with acute exacerbation of COPD, you have to monitor airway, breathing, and circulation. You have to start the patient with low oxygen because you need to keep a CO2 retention to keep the respiratory drive, otherwise, respiratory drive will suppress. So, low oxygen when the PeO2 is more than 60 mm and saturation is to maintain the saturation of more than 85%. Eventually, mask should be used to monitor the FiO2, nasal cannula 5 liter per minute with FiO2 of 40%. When FiO2 is 55% and simple masks are used at 5 liter per minute. Nebulization with salbutamol 2.5 mg diluted to total 3 ml every hourly, ipratropium 500 microgram every 4 hourly, or a combination of duolin, levosalbutamol with ipratropium. You have a newer drug, revafenacin, which is a LAMA, long-acting muscarinic antagonist, inhaled form 175 microgram a vial once a day via nebulization is very effective. Then you have other options such as antibiotics, quinolones, coamoxiclav as erythromycin is an anti-inflammatory and also antibacterial. Prednisolone is not of much use. Aminophylline is not used these days, but if you have to use, you have to give 250 mg and 250 ml of 25% dextrose over 20 minutes. Ventilation, NIV is preferred over mechanical ventilation in patients which have a respiratory rate of more than 25 breaths per minute, mild to moderate respiratory acidosis and hypercarbia. In patients of severe respiratory failure, always go for mechanical ventilation. When respiratory rate is more than 35 breaths per minute, go for invasive ventilation. When hypercarbia, PaCO2 more than 60, acidosis, respiratory arrest, altered mental status, hypertension, hypotension, shock. In these cases, mechanical ventilation is supported. Now, on discharge, you have to put a patient on LABA with inhaled corticosteroid. LABA, you can put on a salmeterol 125, 250, 500 or formoterol. Along with you have to put patient on SABA, LABA with SABA, that is salbutamol and terbutaline. If patient still does not get relieved, again you put the patient on low dose inhaled corticosteroid, dexamethasone, budesonide, fluticasone. Add on, if still not relieved, add a antimuscarinic tiotropium, 2 inhalation orally once a day using rotacaps. You have to tell the patient to take a lot of proteins and less of carbs. Now, very important, long-term oxygen therapy. This has to be given to the patient to prevent the patient from going into pulmonary hypertension. 16 hours a day, 2 to 4 liter per minute of oxygen has to be given to achieve a PaO2 of more than 60 mm. Now, you have to categorize your patient that whether he is in dyspneic state or it is an acute exacerbation. If he is in a dyspneic state, add a LABA or LAMA, and you can add a LABA with LAMA. So, if the patient have a lot of inhaled corticosteroids in the from a very long time, you just give LABA and LAMA. And if the patient is not relieved, you add a LABA LAMA with inhaled corticosteroids. Now, if the patient is coming to you who's on exacerbations and he's on LABA and LAMA, And in that case, you either combine LABA with LAMA or you combine LABA with inhaled corticosteroids. In case when your eosinophil count is more than 300, you give inhaled corticosteroid. If still after giving three drug combination there is no relief, you can add the, if the patient is former smoker, you can add azithromycin, and if the patient is a chronic in a chronic bronchitis state and FEV1 is less than 50%, you add roflumilast. Now, interventional therapy, you go for a lung volume reduction surgery, bullectomy, transplantation, and bronchoscopy. Intervention, we'll see in which condition we have to do what. If the patient is predominantly emphysematous with severe hyperinflammation with large bullae, go for bullectomy. If the patient cannot tolerate bullectomy, patient cannot tolerate a bilateral lung volume reduction surgery, go for lung transplant. Now, if the patient has a heterogeneous, no bulla, but with a heterogeneous emphysema or with a homogeneous emphysema. If the patient have a heterogeneous emphysema with no collateral ventilation, go for lung volume reduction surgery. If the patient have a collateral ventilation, you can try a lung volume reduction surgery or you can try a bronchoscopic lung volume reduction. If the patient has a homogeneous emphysema with no collateral ventilation, the bilateral bronchoscopic lung volume reduction surgery is better. If patient have collateral ventilation, again bilateral these bronchoscopic lung volume reduction surgeries are better. So this was in short the discussion of COPD, which covers a lot of things. Best doubts you can ask in the comment section. So if you have liked the video, if you like the content, please subscribe to the channel. Thank you.